how do surgeons expand their Ferrari and Lambo collections if they're talking people out of labrum surgeries? Well, Dr. Dan Gurley, I get a lot of questions from patients and things that I am not an expert in, believe it or not. And sometimes these questions are about myself. For example, I asked ChatGPT, the AI, the other day, what is my most likely next severe or significant injury? I put in my family history, which some of it, and I put in, my height, my weight, the sports that I have done, that I'm going to do, what I've rehabbed myself from, for example, my Achilles tendonitis, and it spat out Achilles rupture. So I didn't like that. I thought it was going to say some sort of shoulder injury, given that I do CrossFit.
Yeah.
What do you think about that? Is ChatGPT wrong? Is it partly right?
That's a good question. I haven't experimented with it in that realm, looking for predictions like that. I would say the Achilles tendonitis, my own experience, Achilles tendonitis leading to an Achilles rupture. That was my story. I've torn both of my Achilles, and I can remember getting a night splint to try to keep my Achilles and my plantar fascia stretched overnight because my rehab wasn't quite getting it where I wanted to be, and it was not too long after that I had my rupture. So that's my story. I would say it's not uncommon for people to say they've had some kind of Achilles tendonitis before their rupture. Mm-hmm. So I can understand why the AI might point you in that direction. It's interesting in what you do to prevent Achilles ruptures. We have more advanced things like I think we were talking a little bit offline about PRP. I don't know if you've ever heard the story of plyometrics in Achilles rehab. There was the story as I've heard it. It's called Alfredson's protocol, and Alfredson was a medical student or a resident somewhere in Germany, mm-hmm. and he had Achilles tendonitis and wanted the attending to fix his Achilles, and he wouldn't do it because they couldn't be a man down, and so he kept jumping off the stairs trying to tear his Achilles, and the plyometric work actually made him better. So it seems counterproductive to do high velocity Achilles plyometrics, but mm-hmm. that maybe that could be part of your program.
Yeah. As part of my prehab, so my pre-recurrent Achilles tendonitis protocol, I do the box drops where I drop off the box, often landing on one leg. And I also do lots of things like box jumps and burpee jumps, all sorts of things.
Yeah.
With my shoulder, I think I'm pretty smart with my shoulder, so I do, the protocol you see where you lay on the floor and then you push backward and then you do different angles with your arms. Mm-hmm. I do the banded things that I'm also working on, like banded joint mobilizations and whatnot. But, occasionally my wife makes me compete at CrossFit competitions like we did Saturday, where Drew, the media guy, was at. And, of course, given that I have ape arms like this, I don't like butterfly pull-ups, which are the ones that you look like a floppy fish, but you can do about 20 in about 10 seconds. So you're way faster with them. And, of course, the bars are so short at almost every gym that, my knees are like this, so my legs aren't, crouching against the ground. But my shoulders do hurt after these, and I see a lot of athletes, and, a lot of times I will do something like PRP for this. In fact, a lot of my PM&R friends that work for CrossFit, they call it hot shoulder or CrossFit shoulder. Surely you've seen this.
We definitely see, the CrossFitters are pretty good at getting their shoulders fired up. Between the number of lifts they do and the intensity and the velocity, a lot of people find their limits with that.
Mm-hmm. In order to prevent it, other than not doing the activity, one analogy I heard is it's only for competition purposes. It's like a head-on football tackle. Head-on football tackles, not head-to-head, but like shoulder-to-shoulder, that's not improving your health, but for the purpose of the sport, I guess you have to do it. So, I think at non-elite competitions, they should never allow butterfly pull-ups. A little bit of a kip's probably okay. Correct me if I'm wrong.
Yeah, that sounds like pretty good advice.
But for someone that's in my situation or in the situation of my friend, she saw a orthopedic doc, and they said, well, my shoulder hurts from doing these pull-ups and CrossFit activities, and they're like, well, how'd you hurt it? Well, I've no specific injury. I've just been doing CrossFit for a long time. And the orthopedic doc says, scribe, write that down. Is it important that she did CrossFit, or was that person just looking for something to blame it on?
That's a good question. I can't really read their mind, but I suppose maybe they have a little bit of an axe to grind that they've seen a lot of CrossFit injuries and wanted to chart it. Maybe they're doing research and want to know that make sure CrossFit's included in their records for that. I'd be speculating. I don't know.
Mm-hmm. When it comes to the shoulder, a lot of people ask me, well, when is it time for imaging? And I know there's kind of been this pushback against imaging because so many people come to the physicians like yourself, surgeons like yourself, and they say, well, I am 65 years old and I want to stay active, and don't worry, I've already got the MRI. I have torn rotator cuff and labrum. So can you just go ahead and patch those up? What does that patient need to know before they jump in and get these things done?
Well, the first thing I always say is we treat patients and not pictures. So I want to talk to them. I want to do a physical exam. I want to see where they're weak, see where their motion loss is, what their actual deficits are, so we can address those specifically. Because I would say in a 65-year-old, I'm not going to touch their labrum. There's a pretty good study out there that people age 40 to 70 with no shoulder pain that got MRIs had about 70 to 70, I forget the number, 70 or 75% had labral tears. Mm-hmm. And so I don't think labral tears over 40 are really all that clinically significant. I talk people out of labrum all the time when they're in that over 40 range. Mm-hmm. But rotator cuff, if they have a deficit, if they have weakness, they have pain, they haven't been able to make any ground with non-operative care. I think can be a pretty successul way to get them fixed.
How do surgeons expand their Ferrari and Lambo collections if they're talking people out of labrum surgeries?
Well, first do no harm, right? What I've seen over
they keep their licenses.
What I've seen over my practice is you start fixing labral tears in people that are over 35, 40, particularly 40. You end up with a lot of stiffness. The labrum's job is to prevent instability. When you have a labral tear, it creates instability, a loose shoulder that's popping out. Yep. It's very uncommon to see a 65-year-old with a loose shoulder that's popping out. Most people, as they age into their 60s and beyond, have actually lost range of motion, have a shoulder that's stiffer, that doesn't move as well. If I go in and do a tightening procedure and fix their labrum, I've actually made them worse by making them tight and giving them potentially more pain or less function.
Would you fix a labrum in a very young patient with Ehlers-Danlos or on the hypermobility spectrum?
Well, yeah, you just added a big old variable in there. The hypermobile Ehlers-Danlos folks, I would say it's rare for them to have a labrum tear. They're usually loose without a tear. Mm-hmm. That's a more common scenario. But if they did have a labral tear, I'd fix it, and I would be humble in the thought that that's going to make them better for a while, but it's likely that their instability is still going to be present.
Yeah, there's somebody out there with EDS that's about to comment, hold my beer, I got a labrum tear after the... anyways, I've also heard that certain people, maybe those same hypermobile people, shouldn't squat below parallel, or they should only go to a right angle or 90 degrees. What can you tell people, outside of specific contraindications about those deep butt to the ground squats?
I don't call that a contraindication, having a hypermobile person doing a deeper squat. I mean, it comes down to a lot of, what's your training, what's your technique, are you using good form, are you using weights that you can handle and maintain your good form? I don't know that going deep is necessarily something you have to avoid. There's a lot of people who can't do it well, and it causes them pain, and you have to listen to your body as well.
For people who are not injured, let's say myself or a friend, we're doing a heavy deadlift, which I actually think is, if you're doing a truly max effort deadlift, and this is at a heavy weight, I think it's actually impossible to use perfect form. Do you think it's reasonable when people come up to us and tell us, hey, you got to like watch your back or watch your form there, that we just say, if you can lift heavier than me, go ahead and lift, and then you can complain. So I just like to tell people, you can complain about my form if you can lift more than me. Is that reasonable, or is that just someone waiting to break their back out if they're lifting with good form with submaximal efforts?
Well, I mean, to say that the only way you have the right to complain about somebody's form is to do more than them. I mean, that's, you just disqualified every, high school track coach because they can't run faster than their athletes.
Probably most of them.
Right, most of them. Yeah. So, I mean, you don't necessarily you can be a good coach without necessarily being able to do more than what your athlete can do. Maybe you did at one time.
That's reasonable.
Yeah.
Yeah. Back in the glory days, I used to, bench 3 plates when I was a high school football player.
Yeah.
But then I guess what's a good excuse for no longer moving and doing exercise? Like presumably not, like if you get a pec tear, you can still do some things with pushing exercise. But as far as like general movement, is there something, for example, a knee injury that would preclude you from ever doing a body weight squat again?
I don't think there's anything that would automatically preclude you from doing that. I mean, if you had a patellar tendon rupture, it might be a long time before you're going to do that. Like my folks who have quad tendon ruptures are usually a little bit older. Those guys doing a deep squat, it's probably unlikely that that's going to happen. Could you rehab yourself and get to a point of doing that? I'm all for it if you can. I would say the likelihood is relatively low.
For people who have had a pretty bad patellar tendon rupture, is there something that can help accelerate their healing? Peptides, intraoperative PRP, to prevent muscle loss, should those people consider HRT, hormone replacement, if their levels are not great?
My understanding of the literature on that is testosterone replacement, if you're low, is probably the best studied and best supported of all the things that you said. The peptides, some of the other things. I think there's a lot of promise there, but I don't know that I know the answer today. I hope that we do know that answer soon. PRP in the OR, there's studies that say it's deleterious. There's studies that say that it's helpful. It's kind of all over the map. And is it what kind of PRP and what system and what's your real platelet concentration? I mean, all those things. There's so many variables. It's hard to study that and then compare it to your own practice and your own situation.
I had someone last month give me a shout out on the Joe Rogan podcast. They said, hey, Kyle helped me with my shoulder. I'm so glad I didn't get surgery because if I got surgery on my shoulder, it'd be permanently messed up. And, this is just something that someone said publicly. People can go look it up. But that's certainly not the case. And, the telephone game, sometimes it's hard to say, I can't believe this doctor told me that because I have torn my rotator cuff, I should no longer do overhead pressing movements. So, we understand that within our profession is things get slightly changed, and that's okay. But are there specific shoulder injuries where people should go seek out orthopedic surgery or orthopedic care in order to preserve function of that in the long run?
Well, I do a lot of rotator cuff surgery. I think that the studies there are pretty good studies that show that rotator cuff injuries, rotator cuff tears tend to progress over time. I think it was out of WashU in St. Louis. They did a longitudinal study with ultrasound, and they showed progression of tear size over time. There's also some pretty good data that says that rotator cuff tears that have been neglected or have been put off, and there's muscle atrophy. Well, you can get to the point of rotator cuff atrophy where there's fibrosis in the muscle that even if we put it back where it came from, that fibrosis is somewhat of a non-reversible or an irreversible problem where you can't get that full rotator cuff strength back. So in my mind, yeah, try whatever your favorite way of trying to do your own first aid. Is it if it's ice and rest and anti-inflammatories and compression and activity modifications? See your physician, your healthcare provider, but if you're not getting better, there's often it's not unreasonable to think of a surgical answer. I have a lot of patients. Thankfully, I've been doing this a long time, and I think if all my patients were permanently changed for the worse, I probably wouldn't still be able to do this.
Definitely.
Week in and week out.
Yeah, no, I certainly agree. To somewhat play devil's advocate, for a patient that is, perhaps 70 years old and they're not sure when they tore their rotator cuff, perhaps there was some symptom onset pretty recently, other than examine imaging and history, is there a general rule of thumb to say, after this age, you don't fix as many rotator cuffs? Or is there a general rule of thumb to say this many weeks or months after you think you've injured it, it is most helpful to consider a surgical option?
I don't have an absolute age where I would say rotator cuff is a bad idea, but I would say you start approaching 80, it's unlikely that the cost-benefit ratio, not just financial cost, but just cost to your own life, risk, it's hard to see the benefit of going through an operation because a rotator cuff surgery is 3 months of pretty intense recovery and then another 6 to 9 months of recovery. It can take a year. The value add of taking an 85-year-old and putting them through a year of recovery for their rotator cuff, you have to really have a hard conversation about that. As far as time from injury to surgery or injury to it's been too long, a year or two gets to be pretty long. That's when that atrophy really sets in, particularly in an older patient. Not that I haven't taken care of those folks, but
Sure.
but those are more challenging, higher risk, higher re-rupture rate. I'm thrilled when I see somebody in the first month or 2 months with an injury. I think those do so much better. But as people walk in the office whenever they walk in the office.
Yeah, they've done 2 years of stem cell treatments and chiropractic medicine.
Right. Which for a lot of people that might be the right answer, but yeah, sometimes we catch them in a hole where now there's some things that become really difficult to overcome.
You mentioned that for those who need it, hormone replacement therapy or testosterone replacement therapy could be a very good option for preserving function. I have heard that, and this might be true. All of these are legitimate questions. Some of them I'm just plain devil's advocate. That if your muscle becomes strong too quickly, because on average maybe it takes 6 weeks to have a significant hypertrophy muscle building effect, and perhaps the tendon reorganization and collagen organization takes 6 months or more, or much longer, that your muscles become too strong for your tendons and you're going to increase your risk of things like Achilles ruptures or patellar tendon ruptures or even rotator cuff. Is there a lot of truth to that? And is there specific things that people should do, like what I did, which I think is reasonable? When I started CrossFit, it was all new movements, and I just took it nice and easy for the first 6 months. I let my tendons and ligaments and body adapt to it, mostly range of motion. I got my hard workouts elsewhere. Is there something that people should do if they start a new training modality or start hormone replacement?
I like what you said about your own experience of, not trying to win the championship in the first month is a pretty good rule of thumb. Testosterone replacement therapy, creating, peak muscle force that your tendon can't handle. I see that probably more in the anabolic steroid world rather than the testosterone world. But I suppose that's a theoretical, but that hasn't been my experience. But yeah, as you're starting something new and, a new movement, a new regimen, be it CrossFit or a martial art or something that you haven't really done much of before, your body has to adapt to that, and don't try to do too much too soon.
I've always thought those using performance-enhancing steroids, supraphysiologic amounts, tend to be on anti-estrogens, aromatase inhibitors, synthetic anabolics that decrease the conversion to estrogen. And I think that there's a very reasonable theoretical link between deficient estrogen levels and looking great and dry all the time, but also not having healthy tendons.
Right.
So I think that's certainly part of the risk. But like you mentioned, it's hard to parse that out. But we both see it anecdotally.
For sure.
A lot of female athletes specifically get AC joint inflammation and also distal clavicle osteolysis. Some people call it female weightlifter shoulder. Other than maybe modifying your bench press technique or different overhead movements, how can people prevent this or treat this?
Yeah, prevention, I don't know. I usually catch up with it when it's already happening and we're seeing it, in the clinic and seeing it on imaging. I don't have a good answer for prevention strategies. I will say that I'm very slow to consider anything surgical for that. I think it's I refer to it as kind of a nuisance pain. It hurts. It affects your ability to thrive, but it's not a life-altering as far as going to cause major disability. So I'm fine with whatever symptomatic treatment we can do to try to keep them going. In my own practice, I do a lot of corticosteroid injections for that. If we can get the inflammation down and take the pain away, you can keep working out and keep going. And because the worst thing that happens is the operation to fix that, which they're already a candidate when they walk through the door. So I kind of look at it as a low risk way, to let you keep going. And my football players that have maybe more of an acute AC separation, I look at that kind of the same way as, if it's not a truly unstable AC separation, I've been known to do local anesthetic for game time, just go ahead and numb it so they can play. And we've been fairly successful in some players doing that. The one caveat was my quarterback who had a previous clavicle fracture. I don't think I took into account that maybe some of his tissue planes were modified because of his clavicle fracture. And so when I filled his AC joint up with long-acting local anesthetic, it percolated down to his suprascapular nerve and took his rotator cuff away. It was a really bad idea on game day.
Yeah.
He didn't get to play that day.
That does not sound great.
Yeah, when the first two snaps, he couldn't raise his hand to catch it, catch the shotgun snap. We had to pull him and put the backup in. So that's something that still kind of haunts me several years later.
Good to know. It's an interesting case. If you've met my wife, Maddie, you'll know that she's kind of built like a linebacker. And, maybe I want to retire someday. Maybe she can go play rugby or something. I don't want her to get a concussion. But interestingly, she had a clavicle fracture when she was born. She was a massive baby and got stuck and whatnot. But it made her a really good javelin and discus thrower, because kind of that little bit of asymmetry. Fortunately, she hasn't had AC joint issues. And, she has these massive, thick Achilles tendons and these extremely big ankles and calves. So I'm not too worried about injury of Achilles tendon if she plays rugby. But I am worried about ACLs, because I know that although female rugby players have a lot less injuries than male rugby players, people can debate why, probably because they're playing against females, right? Can you assess, I feel like I can kind of look at someone and somewhat assess their risk of a certain type of injury, except ACL. Then if they look female, I consider them higher risk. Is there any other way that someone can assess their ACL risk?
I don't know that there's a score sheet per se where we can, do these series of tests and say you're 2.6% higher risk or 2.6 times more likely. I do know that there are one of the modifiable factors that we can do. We can't change if you have a valgus alignment to your knee. If you're more knock-kneed, that's one of your risk factors. For females, there has been a lot of study on where in the ovulation cycle and they're in the menstrual cycle ACL ruptures occur. Well, we're not going to sit women out of sports for a week or two every month. So there's things that we can't really modify. But what we can modify, there's these pretty well validated neuromuscular training programs. There was one that our physical therapy program was involved in for a while called Girls Can Jump, and that there's some variability in general. The way females jump and land, they tend to be more straight-legged in activities rather than in more of, you used the word linebacker earlier, kind of a linebacker stance where you're bent knee, butt down kind of positioning that in general women tend to be a little more knock-kneed and straight-legged. Again, these are terrible stereotypes, which I hate to be saying on the air, but
maybe better than nothing.
But if we can learn to play in more of a bent knee, butt down kind of position, that's probably ACL protective, and there's some fairly well validated programs like that.
Yeah. Well, that seems very actionable.
Yes.
Last question. I have a friend that has had many ACL surgeries. You did his last one more than 5 years ago now. Not to jinx it. Knock on wood. Yeah. And it seems like there's this certain subset of people who have had multiple ACL injuries. Presumably they're doing this same type of thing. Do you think this is primarily genetic or bad luck or some other factor we don't know yet?
I think it's multifactorial. I think certainly there can be bad luck. There can be genetic. There can be the way they move, neuromuscular training might help, although physical therapy addresses that usually. I think there's also the concept in any joint, but knee in particular, we talk about primary stabilizers and secondary stabilizers. And there's kind of this diminishing returns. The more times we fix an ACL, the more the secondary stabilizers are also injured. So your capsule gets stretched, your meniscus gets torn, your collateral ligaments are sprained, changed in some form. And so, instead of having 5 things holding your knee in place and just replacing the one that's torn, now we keep asking that ACL to do more and more because the secondary stabilizers aren't doing their job.
Well, that is some fantastic information. I really appreciate it. We'll post your information for those who want to see other things that you've done and link to your biography and whatnot. And finally, I hope that I never have to see you in clinic for an injury, but I would not be shocked.
Sounds like a good plan. Didn't we see each other like in the lobby of a hospital one time when you had like
I think
wasn't an ankle
or
something?
I think I know I had a broken ankle, and then at some point I had maybe some patellofemoral syndrome as well. Yeah.
I remember meeting you and your mom in the lobby of a hospital to look at something once upon a time.
Yeah, probably my ankle.
Ago. Yeah.
Probably my ankle or my knee. But fortunately, since I've gone through my very late puberty and growth spurt and whatnot, I've been relatively injury-free.
Well,
so it was really
hopefully you can not inherit the bad genes that I know exist in your family.
Yeah, I probably inherited all the good genes. But yeah, I mean in actuality, I liken my style of training to a deer that lives on the most popular game preserve. The deer that are there are really good at avoiding the hunters.
Yes.
And you see people at, doing functional fitness, and I'm still sprinting and doing track workouts and 400-meter dashes and, playing what I call church league sports, doing CrossFit. If you can make it 6 months, a year, 2 years, and then avoid ego lifting, ego running, ego crossfitting, and ego sporting, then I think that really helps.
I agree.
Yeah.
But yeah.
Anyways, for the audience, if you have any questions for either one of us or any concerns, nice comments, mean comments is all good for the algorithm, please post below. And as always, may God bless you with health and happiness.